more so on. So we'll get to that towards the back end of the semester. So today, guys, we're talking about neuromuscular disorders. This is part 1 of a 2-part lecture. So we're going to talk about 2 conditions today specifically, being stroke and Parkinson's disease, and then next week we'll hit another 2 separate conditions. So you've got your key references here in terms of your kind of formal readings that we recommend you hit, so your ACSM guidelines and the textbook as well at the top, so your exercise management for person with chronic disease and disabilities. I do highly recommend you get onto those. Obviously for the sake of a lecture, we're pretty much just scraping the surface and hitting the main information. If you want to get a little bit more in depth and you've got a particular interest in these areas, then I really recommend those chapters. Other resources, so I try to provide these each week, just kind of your go-tos in terms of online resources, reputable, your key charities and organisations that are working with patients and families and practitioners in this space. So you've got your Australian Stroke Foundation at the top, and then also Parkinson's Australia. Really good websites, as always with these. I just think they're fantastic for kind of simple information, simple but accurate information. So if you are struggling to get your head around any of this information, go on there, have a look through some of their patient information sheets, watch a few of their videos, read over some of the resources, and hopefully it'll start to sink in a little bit better. So in terms of neuromuscular disorders, guys, so what we're talking about here is any kind of condition that's related to either the neural or the nervous system or muscular tissues of the body. Okay, so like I said, 2 we're going to talk about today, stroke and Parkinson's disease. So you guys might already be somewhat familiar with those 2 conditions. Next week we're going to look at multiple sclerosis and muscular dystrophy. Okay. So kicking off with stroke to begin with. So we're just going to try and explain, well, first of all, a little bit of context in terms of the prevalence and statistics in Australia, and then obviously just kind of give you an overview and get into that pathophysiology. So stroke is currently the third leading cause of death in Australia. In 2017, almost 500,000 people were living with the effects of a stroke, so they were, stroke survivors. And 65% of stroke survivors suffer a disability that actually impedes their activities of daily living. So we know how basic those tasks can be. All right. The economic burden in Australia is estimated at about $5 billion annually, so it's absolutely huge. And an interesting point is over 80% of strokes are actually believed to be preventable. Okay, so obviously exercise can play a key role in that, which we're going to get to later on. So there's different types of stroke just to be aware of. Now, if you haven't ever sort of done any study or heard much about strokes previously, there's going to be a few new terms today, and it might be kind of hard to keep up with them all. Just take your time, you don't have to be an expert on stroke by the end of today, but hopefully just start to get your head around kind of the different types and how strokes present. So a stroke or a cerebrovascular accident, a CVA, so they're interchangeable terms, they're referring to the same thing. So a stroke ultimately occurs when blood to the brain is disrupted. Okay, so that blood flow and that blood supply to the brain is basically disrupted. And that's obviously supplying essential oxygen and nutrients to the brain. Okay, so we can almost think of this as a brain attack. Similar to your heart attack, we've almost got the same thing going on in the brain. Okay, now 2 key types to think about. We've got ischemic stroke. Now this makes up about 80 to 90% of total cases. And we've got hemorrhagic stroke, okay, which is the remaining 10 to 20%, so less common. In terms of ischemic, this is where a blood clot or plaque, which is usually due to sort of cholesterol buildup, actually blocks that blood vessel. Okay, and hemorrhagic strokes are where the blood vessel actually in the brain leaks or breaks or ruptures. Okay, so ischemic and hemorrhagic, and we know that ischemic are far more common. So just to not complicate things, but just to note, there's actually 2 different types of ischemic stroke. Okay, so we've got thrombotic. Now this is where that buildup of plaque eventually blocks the artery, preventing blood flow. And it most often affects major arteries in the neck, which we can imagine are going to cause issues for getting blood to the brain. So this is what we can see on the left-hand diagram at the bottom there. Okay, so you can see that thrombus, we call it, blocks the flow of blood in the brain. We've then got an embolic stroke, okay, where that blood clot or that plaque actually develops in another area, which is usually the heart. That's the most common site. It actually breaks off, so dislodges from the artery wall, it travels in the blood vessels towards the brain and it blocks the artery. Okay, so just again trying to get your head around the differentiation there. So we've got ischemic, hemorrhagic, and within ischemic we've got thrombotic and we've got embolic strokes. And I know we're kind of skimming over this quickly, so don't panic if you're not keeping up too well. Just try and kind of soak in what you can at the moment. So moving on to the second category, so like we said, sort of 10 to 20% of total strokes, stroke cases are hemorrhagic, okay? So caused by a break in the wall of a blood vessel in the brain. That blood is going to leak into the brain and obviously stops delivery of oxygen and nutrients. Again, two different types of hemorrhagic stroke that you want to be familiar with. So we've got intracerebral, okay, so that's when an artery inside the brain bursts, bleeds into the brain, and the most common cause to be aware of is actually hypertension, okay. We've then got subarachnoid hemorrhage, or SAH as an acronym, okay, and that's where this bleeding on the surface of the brain actually occurs, and you can see that on the right hand side there. On the right of the diagram. So you've actually got layers of membrane that cover the brain, and your SAH typically occur between the layer closest to the brain and the second layer. Okay, so you get this kind of spread in this surface bleeding, okay, which I know isn't a particularly nice thought, but it's just, again, looking at the visual there, I think that helps see the difference. So in terms of causes of stroke, when we're thinking of hemorrhagic stroke, okay, we can potentially have an aneurysm. So this is where you get a weak spot in the arterial wall. Ultimately, it balloons out. As it gets bigger, it's becoming weaker and more frail, and it can lead to a burst, okay? So therefore, we're going to leak blood. Typically, they develop over the long term, so over multiple years. The tricky thing is, and the difficult thing is they're often asymptomatic, I should say, not symptomatic. So often they go unknown for multiple years until the point that they burst, and then obviously there's a cascade of events that sort of leads to the aneurysm. But sometimes it can actually be too late at that point. So a burst aneurysm is usually caused by chronic hypertension, or it could potentially be some kind of trauma. So for instance, like a sudden head injury. But I'd say more often than not, it's going to be some kind of chronic condition and most likely hypertension. We also have what we call an arteriovenous malformation, or an AVM, so another big term, okay? So just to kind of explain this, what we're talking about is a tangled mass of blood vessels, which can ultimately occur anyway, but including the brain, okay? So they are usually present at birth. They may become bigger and weaker with aging. Again, guys, asymptomatic until the burst actually occurs. And if the burst occurs in the brain, then that's typically going to lead to what we call a hemorrhagic stroke. Okay, so that's talking about the causes, what can actually cause that taking place. Another new term to think about is our transient ischemia attack, or TIA. Now, this is what we refer to as almost like a minor or a mini stroke. So the signs of the stroke are present from anywhere between minutes to 24 hours, but not necessarily over 24 hours, so it's kind of that more acute phase. So the blood supply to the brain is ultimately being disrupted for a shorter period of time. Causes and symptoms are similar to those of a standard stroke, so you get weakness, numbness of the face, potentially in the arms and the legs, and we're going to talk about all of this. Difficulty with the speech, understanding, comprehended, so a little bit of cognitive dysfunction, and also swallowing. And then potentially headache as well, which can have quite a severe onset, a sudden onset, which can then also cause dizziness and loss of vision as well. Big point with these guys is a TIA, a transient ischemia attack, is ultimately a warning sign for a stroke to potentially take place in the not so distant future. So prompt investigation is required. It's really important that individual receives treatment and looks for investigation, whether there is any kind of signs that a stroke could be in there, occurring, and there's some alarm bells there. So 20% of individuals that have a TIA experience a major stroke within 3 months. Okay, so the greatest risk is actually in the initial following days, hence why urgent medical treatment is really, really important for these individuals. So just thinking about some risk factors for stroke, so we've got our modifiable risk factors, which we're hopefully becoming quite familiar and comfortable with. Okay, Very consistent for a lot of the conditions that we look at and a lot of the different pathologies. So we've got hypertension, which we've spoken to a few times, high cholesterol or dyslipidemia, so excessive cholesterol levels, which we know are going to have a contributing factor to that build-up of plaque in the arteries. Tobacco smoking, alcoholism, obesity, and obviously physical inactivity, which we talk to every single week. Non-modifiable, so there's going to be that age component, as we know. In terms of stroke, women are actually at a slightly higher risk. And there's also known to be some greater risks in your sort of black and Hispanic ethnicities as well. Previous stroke, just like kind of a musculoskeletal injury, once you've injured an area, you're much more predisposed to a secondary injury, okay? So when somebody suffers a stroke, they're more at risk for a second stroke, basically. So in terms of diagnosis, now obviously there's some quite sophisticated techniques involved. So CT scan, so computerized axial tomography. Now this is usually used in that acute period, and it's really important for trying to rule out other conditions. So for instance, if there's any kind of suspected tumour, your CT scan can usually do the job of saying yay or nay. We've then got our MRIs, which are potentially a little bit more accurate for subacute assessment. So in that kind of post-initial acute, period of a few days, that can potentially answer those questions. As we said though, guys, either CT or MRI should be performed urgently within 24 hours post-stroke, okay? So that really helps us determine the type of stroke and obviously tries to help set up that kind of treatment and post-stroke survival plan. At the same time, an ECG is going to be recommended for all patients, okay, just to kind of look at if there's any arrhythmias present, okay, any issues with the ECG trace. Echocardiogram, which is basically just an ultrasound on the heart, so you can look at the size of the chambers and make sure there's no damage to the walls, etc. And then also various blood tests might take place, again, once more, just to look at ruling out any other possible conditions. So just a note here, guys, I guess the main point here is where that stroke actually occurs, or where that where the blood clot and where the bleed actually occurs, is going to have a big impact on the consequences that individual suffers, basically. So we know that the brain is separated into various lobes, okay, and each of those lobes are responsible for different functions, ultimately, okay. So if we look at the frontal lobe, this has a lot of responsibility with our movement, thinking initiation, reasoning, so things like making judgment, your behaviour and your emotions, and also memory and speaking. So we know if we get a stroke or a hemorrhage or a burst, an aneurysm in this area of the brain, and these are the kind of functions that we're going to most likely see deteriorate and have issues with post-stroke. If we look at the temporal lobe, so just below that in the green, understanding language, behaviour, memory, hearing, so you can see there is some crossover. But once we see the imaging via the CT or the MRI, and we know where the stroke has taken place, then we can be a little bit more specific with the kind of treatment and recovery and rehabilitation that individual is going to receive. Okay, so you don't need to know kind of all the different lobes and all the different responsibilities and actions of those lobes, but it's just to kind of make the point that the location is fundamental to the kind of the rehab experience, the treatment, but ultimately the symptoms that person is going to experience post-stroke. So we've probably all seen one of these before, whether it's in an advert, there's a different foundation back home, but the message is always the same. So it's all about that fast response, basically, and they use the acronym FAST here. So if you recognise a stroke, you've got to think fast, and that prompt response is really, really crucial. So the kind of clues and the cues that they use here is, has their face dropped, and we'll talk about these different effects shortly. Can they lift both their arms? Is their speech slurred? Do they understand you? And if you're worried about any of these things, it's time to call 000. And it's just awareness and education, guys. And fortunately, most people, if they're with a family member or a friend or whoever it might be, they're probably going to realise something's not right. But obviously, just reassuring that individual, calling the ambulance, and just monitoring the symptoms is really crucial in that instance. So just a little bit more on specific signs and symptoms. So we've got a few different brain regions down the left-hand side. So we're looking at, like I said, that kind of location-specific damage taking place, and what are some of the various signs and symptoms that we might see. So if we're looking at what we call the Wernicke's area, which is placed in the temporal lobe, some of the signs and symptoms, so difficulty speaking and comprehending, so making sense with their speech, confusion between the left and the right, difficulty reading, writing, naming objects and calculating. The Broca's area, which is placed in the frontal lobe, so this might be again difficult with some speech and sometimes writing. The parietal lobe, specifically on the left-hand side of the brain, loss of coordination on the right side, so in terms of the limbs on the right, and etc. etc. So again, I don't need to kind of go through the whole list and exhaust it, but the point being, different areas of the brain are obviously going to have different consequences and more indicative signs and symptoms, okay? So what are some of the complications following a stroke? So ultimately, stroke causes upper motor neuron injury, okay? So that results in some of the following. Hemiparesis, so this is basically weakness on one side of the body. So it ultimately reduces the number of recruitable motor units during activity, okay? So again, some of you guys might be quite familiar with stroke. You might have, I hope not, but you might have had somebody close to you experience a stroke, so you'll be quite familiar with how this is actually, presented. But no doubt we've all kind of, at some point, whether it's on TV or whatever, we've seen somebody that expresses that kind of weakness on the one side of the body. And like I say, this is what we refer to as hemiparesis. Paralysis, so that could be a complete loss of function in one or more limbs, depending. Spasticity, so this is that really extreme muscle tension, which you can actually see in the images on the bottom there. So there's actually some disruption to the stretch reflex, which means that muscle is basically contracted and really stiff and rigid chronically, okay? So that's where sort of flexibility and physical therapy comes in really importantly there. There can be a lot of pain associated with that as well. Sensory perceptual dysfunction, so these are your balance and your motor coordination problems, which again we could obviously intervene in terms of an exercise treatment side of things, and aphasia, which we spoke about, being your speech and your language deficit. So depending on the severity of the stroke, what that individual has specifically experienced, we can see there's a whole host of considerations here that as an exercise professional we're going to need to consider, okay? Obviously the physical, but then also the potential, the cognitive, and the speech, etc., etc. It's all going to be impacting us. So in terms of impact on physical function, the level of your post-stroke physical function is going to be dependent primarily on two things. Number one being your pre-stroke fitness level. Again, that's kind of relevant to a lot of different conditions, particularly if you think about surgery. Going into a surgery strong and fit, you're going to have far less of a decline and far less issues physically when you come out of that surgery. Similar kind of scenario with a stroke, okay? So if an individual is fairly conditioned, fit, strong before a stroke, we're going to have less of a drop post-stroke. But when we think about the population that strokes typically occur in, it is that aged population, okay? We know that there's an aging effect, so they're going to occur more regularly in your aging population. And we know there's issues already there in terms of, physical inactivity, sedentary behaviour, atrophy of the muscles, reduced cardiovascular fitness. So typically people don't always have a very strong level of fitness before a stroke in the population that it typically arises in. Also neurological involvement and existing comorbidities. So again, if people have got a lot of different things going on, then of course that equally is going to impact that physical function. So just a few stats here. So your aerobic performance, generally speaking, can decline up to 50%, which is coupled with often 1.5 to 2-fold increase in energy cost of gait. Okay, so we're getting, we're a lot less fit, but then we're also finding it extremely more taxing in terms of just simple walking gait. Okay, so what happens is there's this really kind of exacerbated fatigue effect. So simple activities of daily living become very fatiguing. We get this reduced tolerance, and your capacity changes are more so associated with altered biomechanics rather than a physiological limitation. So we know we've got the physiological limitation of our aerobic capacity is now significantly reduced, and then altered biomechanics and all the motor coordination factors and symptoms that we spoke about in the previous slide are obviously going to have a big impact as well. And simple activities of daily living we talk about every week. But people become exhausted, you know, trying to eat, bathe, dress, trying to transfer themselves in and out of bed. All these things become really, really demanding on the patient, on the individual. So we're just going to look at a sort of general overview of exercise rehab in stroke to begin with, and then we'll get into the more specifics. So just on a whole, what we need to do is we need to start early and conservatively. Okay, so we're going to start very low. Now that's also going to depend on the severity of the stroke and the symptoms and everything that's happened post-stroke. We obviously want to have an awareness specifically of the biomechanical issues affecting that exercise economy, because then we can try and be a little bit more targeted with our approach. We need to progress gradually, okay, so we're not going to be trying to hit any major progressions in those early stages particularly, so we need that conservative increase in load. We can use RPE as an intensity guide, which is pretty common across our clinical populations. And of course, guys, we just want to develop all the fitness components. So there's going to be a benefit of increasing that aerobic fitness, obviously the strength component, but also your flexibility. Focusing on proper technique is always going to be crucial, of course, but particularly where we do have a lot of kind of motor issues and we might see a lot of that spasticity, then we might have issues with gripping, we might have issues with the cadence, so the rate that we can move at, etc. So you really just want to try and strip it all back and get that technique there first and foremost. Then you can obviously start to progress in terms of your load and your intensity and your volume, etc. And mental well-being, guys, so it's obviously cornerstone to any kind of ex-rehab program, but once we can start to empower people with a little bit more physical function and help them see some improvements, then we know we're going to be really catering to that well-being side of the coin as well. And just a note there, exercise therapy is typically used for about sort of formally 3 to 6 months post-stroke. And in that time frame, we're hoping to get people to a kind of, a point of independence where they can then continue with the exercise and try and really build that lifelong independence and get them back to where they were previously before the stroke. And depending on what position they were in previous to the stroke, we actually want to improve that and really try and prevent any kind of secondary issues. So gait training can be really important in stroke rehabilitation. This is probably a more kind of common across the board area that we're always going to have to focus on. And a device that we typically rely on is what we call an assisted treadmill. So this is where we use this harness and we control that weight-bearing gait therapy. So we can obviously reduce the body weight basically. And this is really important, not just for the loading proportion, but just actually getting that gait and that motor control back to where it was pre-stroke, okay? So this is really important, particularly where there's lower extremity paralysis or weakness, okay? So the harness suspension, as we said, it supports necessarily, the necessary amount of body weight required. So that can obviously be variable for different people, but it just allows the individual to work on that gait while relieving that kind of loading component. And it can obviously provide a lot of assistance, specifically when we're looking at individuals progressing from the treadmill and actually getting them to hold their own body weight and walk as normal once again. In terms of cardiovascular training, so one thing to note early on is we might need to focus on performing these types of exercises in a seated position. So looking at your recumbent bike, for instance, on the right-hand side, this is a really easy one to use. We also, as a practitioner, so as an exercise practitioner, we need to be the reason we need to be quite conservative and careful in those early stages is it'll take some time to really understand the balance impairment, the physical ability, and get to know your patient. It's a very complex scenario, so you don't want to be trying things that you think couldn't work. You always just want to go with, okay, I know this is what they can currently do. We're going to work on this and build up over time. We know in that seated position we're going to help reduce and minimise that fatigue. There's obviously going to be there's going to be no risk of falling for the most part. So your use of ergometers in that setting is really helpful. And those with walking difficulty, they should undertake tailored repetitive practice walking. And again, like we said, guys, that can be mechanically assisted gait training as well. And we can use like the parallel bars, which are there on the right-hand side. Obviously, any kind of fear of falling, that's going to assist with that, but also help reduce that load component as well. So I guess it's kind of similar or a slightly less expensive version of the harness assisted treadmill. And as we said, guys, any client with a severe balance problem, there's going to potentially be that increased risk of falls on the treadmill. Now, the harness usually does take care of that, but it's kind of still not the most, it can be still a little bit intimidating getting somebody with a severe balance issue onto a treadmill where we know it's mechanically motored and we haven't really got control of that, versus using something like parallel bars where we can assist and support as necessary. So on to strength training. So a big key here, guys, is we're trying to facilitate improvements in our ADLs, and we know that a key mechanism for doing that is trying to promote neuroplasticity in the brain, okay? So that's basically that learning, that skill learning. So some of the considerations that we need to think about, there is a high dropout rate of stroke survivors in strength training. So to me, that just jumps straight to the last point, which is education. Like education, why are we doing it, why are we doing it, why are we doing it? That's going to be really key to getting people to, embrace strength training, adhere and comply over the long term. We want to be focusing on function task-specific activity. So what does this individual need to achieve on a daily basis to live a good, healthy, normal life, and really try and target those kind of movements initially. We need to understand that the muscle weakness that we're going to see presented might have actually altered joint mechanics. So we need to be wary of that in the movements that we select, in the exercises and the setup that we use. There might potentially be some possible pain or impingement present. And we obviously really want to try and increase or decrease the risk of falling, I should say there. But obviously, just increase strength and get people less likely to have an injury. So in terms of our ACSM guidelines, you can see them here. I apologise once more, they're not always as clear, but this is cut straight off the electronic book copy. So aerobic resistance, flexibility as always. I guess if you just look at the aerobic, it talks about the seated options at the bottom and the balance considerations and the type of machines that we use. Resistance, again, it notes about some equipment considerations. So looking at machine versus free weight, that's an obvious one to start. Bar versus hand weights, seated versus standing, etc., etc. So these are all things that we need to consider. Might sound really simple, but if they're overlooked, then you don't want to be the person responsible for someone having a fall in a gym, and obviously that's going to have a massive impact on their likelihood of engaging in that exercise moving forwards. So with your flexibility, this is obviously quite specific depending on the person's limitations in those early phases, but again, we're just trying to hit overall good whole body mobility and flexibility moving forwards. But like we say, if there is any kind of rigidity or tightness in certain areas, then we're going to have to be a lot more targeted with those parts. So further special considerations, messed up my transitions here, but just a few things to consider as well. Majority of stroke sufferers are elderly, which we've noted, and have other comorbidities. So there might also be other cardiovascular disease types present, potentially arthritis, which we spoke about recently, and metabolic disorders. So potentially, your metabolic syndrome or type 2 diabetes. And we know that each of those conditions all have their own special considerations. So that's where it gets next level complex, in the sense that we have to take care of the stroke, but we're also considering these other things as well. They don't just get neglected. Now this individual has suffered a stroke. It all matters, and we need to cater to all of those things. Obviously, we need to consider all medications as well, and specifically look at their effects on exercise response. Okay, so and this all comes out, obviously, as you know, in that subjective review. The whole screening process, confirming in any kind of subjective interview, what they're taking. And obviously having your own understanding and doing your own research as to how does that potentially impact what I'm trying to achieve and the adaptation that we're chasing. Avoid the Valsalva manoeuvre. We're trying to avoid any excessive increases in blood pressure. Really importantly, guys, obviously we're chasing these physical adaptations, and we're trying to, which we know is going to have a nice carry-on effect to the mental well-being and the mental health as well. But we can't be so focused and narrow-minded about the exercise and the movement that we forget about other effective issues. So thinking about looking at mood, motivation, being aware of their emotional behaviours. So are they frustrated? Are they confused? So that close supervision is going to be really vital in this aspect. And also trying to involve, significant others, family members, to really get your head around that and kind of get a feel for the individual and where they're at. and it might require, you know, repetition of instructions. So they might not respond to you cueing an exercise in a certain way. It might take 3 or 4 times before you get the outcome that you want, but you just have to have the patience and the understanding that, you know, they are still suffering some kind of cognitive dysfunction, and you're potentially just going to have to get really creative with the way you prescribe and you cue your exercises. So also always looking at, you know, so this is how I coach this movement. It's not working, so plan B, plan C, plan D, etc. So we know that early onset, specifically local muscle and just general fatigue on the whole are really common. So we really need to consider that when we're guiding our work rates and also the progressions, okay, within our programming. Okay, so next we're going to talk about Parkinson's disease, which again, hopefully you guys have some awareness of, but obviously we'll probably get into a little bit more of the specifics regarding the pathophysiology than you might have previously, and then, you know, the best part and the part that we're most concerned with is the exercise rehabilitation. So just to paint the picture again, specifically within Australia, we've got around 110,000 people living with Parkinson's disease, which I'm going to abbreviate as PD in the slides. It generally affects those people in the mid to later years. So similar to stroke, there typically is kind of an aging component, and the average time from onset to death is 12.4 years. The economic burden of Parkinson's disease was estimated at almost $10 billion in 2014, which is huge. So in terms of your pathophysiology, so ultimately Parkinson's disease is a chronic, progressive, neurodegenerative disease, okay? Now, in simple terms, what's happening is our dopamine-producing neurons are lowered. Okay, so we've got a reduced amount of dopamine-producing neurons in what we call the substantia nigra. Okay, now this is placed basically, if you just look at the bottom image on the right-hand side, you can see your substantia nigra is kind of in the central brain region, and it's specifically in an area that we call your basal ganglia. Okay, now a few new terms again. Okay, so try not to stress about that too much, but ultimately we're concentrating on this reduced dopamine-producing neurons in the kind of center of the brain. Now, dopamine, which some of you guys might know, it's the chemical messenger responsible for transmitting signals within the brain for the coordination of movement. So we can understand that where there's an issue with this kind of chemical messenger and we've got reduced amounts, we're going to have implications for our movement, okay? And if you just look on the left, you can see you've got your normal neuron at the top, your Parkinson's affected neuron at the bottom, and you can see that reduction in dopamine release, okay? So we've just got a graph here kind of looking at that dopamine depletion in Parkinson's disease over time. So we've got the patient age across the x-axis at the bottom, and we've got the percentage of dopamine neurons across the y-axis. So normal aging, we do see a slight reduction in dopamine over time, but as you can see, nothing compared to what's presented by Parkinson's. Okay, so few different lines here. So early onset PD, so this is obviously going to occur earlier in somebody's life. We're going to see the most rapid decline over time, and that's obviously because the disease is just present for longer, so it's just a time factor. And they're going to reach that Parkinson's disease motor symptoms threshold the earliest in life, okay? If we look at idiopathic Parkinson's disease, and we'll talk about what idiopathic means, basically the cause is unknown, we get a slightly slower rate of depletion in that dopamine, and therefore those symptoms are going to be expressed at a later stage of the disease onset. And there's also just a point there regarding environmental and genetic factors, which we know is a potential cause and one of the most kind of commonly investigated and explored areas in terms of risk factors for Parkinson's disease or causes. So the rate of progression, it's really important to note that it varies so differently between different individuals, okay? So there's no kind of one-size-fits-all in how Parkinson's is basically detected and how it progresses over time. So typically, it's going to progress at a really slow rate, and for a lot of people, the longevity of life is not often that shortened, okay? And if it is, it's usually quite a minimal impact, if you like. So treatment can alleviate the symptoms and it can help with the management, but it's never going to actually stop, cure, or slow the progression of the disease. Okay, so it's basically uncurable, if you like, at this point in time, but there's a lot we can do in terms of treating the symptoms and helping people live a a better and more fulfilling life. The duration, so it does affect the individual, linked to the previous point, for the remainder of their life, and it is ultimately going to get more severe over time with that progression, but we know that it typically does progress at quite a slow rate, but that is going to be variable for different people. So what are some of the risk factors for Parkinson's disease? And it's still quite an unknown area, and there's a lot of research that goes into it, but idiopathic basically refers to the fact that there's no known cause, okay? So again, I missed an N off that there. So the causes of Parkinson's disease, it's a long withstanding discussion in worldwide research, and there's a lot of different theories existing, but the most commonly explored areas are the following. So exposure to environmental toxins, so chronic exposure to things like pesticides are potentially seen as a risk factor. Oxidative stress at the mitochondrial level, so this is a natural process which occurs with aging, but it ultimately causes this release of free radicals that we know can basically reap havoc in the body and potentially be a risk factor as well. There's a genetic component as usual, so family history is sort of believed to be potentially the cause for about 15% of cases, and there's been various different Parkinson's disease genes identified over the years. Now, the onset of genetic Parkinson's at a younger age is more likely to be genetic than any kind of sporadic idiopathic form, okay? So in your younger patients, it's typically more so going to be a genetic form. Finally, it could be multifactorial, so there could be a combination of environmental plus genetic factors that are going to cause that individual to develop and express Parkinson's. So in terms of key symptoms, there's 4 that we're going to kind of focus on, and then there's a lot more others that we're just going to briefly touch upon. So bradykinesia, okay, so think of bradycardia is basically slow, reduced movement speed. So we know bradycardia is reduced heart rate or lower heart rate, okay. Bradykinesia is slow or reduced movement speed. And again, if anyone's had any exposure to Parkinson's patients, you'll know that ultimately, especially when the disease has progressed, they move very slowly, okay? And that can be limb movement, that can be walking, which pretty much turns into like a shuffle, which we'll talk about. But this is ultimately the most disabling symptom, okay? It affects critical function, so thinking about walking, talking, swallowing, speaking, everything slows down. It's usually unilateral, so it usually only occurs on one side initially, and it's, again, in those early stages, it's usually confined to distal muscles. So, for instance, your fingers, your hand, your wrist, etc. Tremor is one that we're probably all familiar with as well. So this is this involuntary trembling or shaking, usually at rest. If you've seen any interviews with Muhammad Ali, you'd have likely seen this as well. And this is present in about 70% of cases. So people think this is kind of the biggest symptom because it's probably the easiest one to see. But yeah, there's still 30% of people with Parkinson's disease that actually don't suffer or express tremor. Muscle rigidity as well, okay? So this is one of our key 4 symptoms. So this is where we see this real kind of rigid, stiff muscles in passive range of motion. It can be your extensor and your flexor muscles. Again, typically starts as unilateral, can progress to bilateral as the disease progresses. Once more, it's common in your wrist, but it can also be in your shoulders and in your neck. And quite often than not, there's going to be associated pain with that rigidity as well, which once more is something that's obviously going to be important for exercise prescription. Finally, postural instability and gait difficulties, okay? So again, it kind of develops a little bit later down the disease progression. What we often see is a slight flexion of the neck or the trunk with a slight lean to one side. So we often start to see this real forward posture over time. Gait changes, that should say, so reduced arm swing, which is typically only unilateral to begin with. We can get a shortened stride, height and length, and that leads to this kind of shuffling that we might see in our patients, okay? Other potential symptoms is going to be sensory consequences, so you might have numbness, tingling, feeling cold, loss of sense of smell in about 40% of your cases. Fatigue, this is a big one as well, so fatigue that's not relieved via rest is a really common early symptom, so that can sometimes be the one that causes the further investigation. But what we know is when people are fatigued, they're unlikely to be active, okay? So that can actually exacerbate any kind of tremor and other symptoms as well. Cognitive impairment, so things like memory difficulties, that can look somewhat similar to dementia. Depression and anxiety is going to be really big, so anxiety can actually exacerbate motor symptoms, that's what we know. Depression is commonly experienced actually prior to diagnosis, which again can be another kind of warning sign and alarm bell, and that's due to chemical imbalances in the brain. And obviously, with all of these things going on, we're going to see a reduction in physical activity. It's pretty much inevitable, okay? So therefore, we're going to get the muscle weakness, the atrophy, the reduced muscle length, the decreased range of motion, aerobic capacity, and obviously that's all going to have a really big impact on your ability to perform activities of daily living. A few more to talk about, guys. So an interesting one is difficulty sleeping. So it's actually known that Parkinson's disease patients often have an increased sleep latency, which means it takes them longer to actually get to sleep. And then when they are trying to sleep through the night, they can get, they can have quite a restless sleep, and that can be due to various reasons: leg cramping, differences in kind of muscle rigidity, pain potentially, and that affects again a large proportion of patients, so about 70%, which could then obviously have an impact on the fatigue component, and that could again sort of worsen and heighten that physical inactivity. Loss of speech, so this can often come out as a bit of a stuttering kind of speech, swallowing issues, postural hypotension. Now this is where when we go from like a seated or a laying position to sitting or standing, we're gonna experience low blood pressure, and that can lead to dizziness and fainting, etc. Some of the Parkinson's disease medications can actually contribute to that as well, but again, something to consider if we're working in an exercise environment. It can be excessive sweating or overheating, sensitivity to different temperatures, which again, you can relate all of this to an exercise professional, okay? So it is important to consider what the individual that you're working with is actually suffering with, what are their specific symptoms, because it's likely not going to be all of these, but you need to know what, and then obviously consider that in your training program. And a big one, guys, is when we're working with these individuals, they're not living the social life that they probably want to live. So if you think about some of the implications of, the speech, for instance, alone, that's going to reduce their ability to communicate, and it can often lead to kind of avoidance of social situations. And that for, the individual is likely going to become isolated over time. So it's probably not going to happen in the first stages of exercise rehab, but if we can get people into more of a group and a social atmosphere, then that's potentially going to have really good benefits as well. So in terms of diagnosis, the onset of Parkinson's is very much gradual, and therefore confirming a medical diagnosis might take a little bit of time. It's not going to happen straight away, but thinking about the different symptoms can actually really aid in that diagnosis, and then also trying to think about the severity of the condition and where it's at in terms of its progression. So early disease, it's only minor symptoms. We might see a little bit of tremor, a little bit of muscle stiffness. When we hit the moderate kind of phase of the disease, you're getting a mild to moderate tremor now. You're starting to see some sort of more severe limitations in your movement. And then as the disease becomes more advanced, we're going to have a significant limitation in our activity, and that's regardless of treatment and medication. So we know we're in those kind of further progressed stages. So currently there is a lot of research going into trying to find and confirm biomarkers which can try and help that diagnostic process by providing a definitive test. And some other things that will often take place within this kind of examination is a neurological exam. So that's going to try and reveal some of your different and specific motor issues. So, for instance, balance and whatever else it might be. An MRI, again, similar to in stroke. So that'll help us rule out any various different neurological conditions that might still have a question mark next to them. And then also your medication response. So it can provide a positive indication of how you're actually responding to your medication. So just the classification system to be aware of in terms of Parkinson's disease. So we've got the Hoehn and Yahr scale here, and this actually helps us kind of define what stage a patient is in. Okay, so we've got stage 1 to 5. There is a stage 2.5, so right down the middle, take note of that. But again, we can see we're just going from kind of the mild early symptoms to the more, at the end we've got stage 5, wheelchair bound or bedridden, unless assisted. So the very end stages of the progression. So just something to be aware of. And this is in the ACSM guidelines as well, so it is endorsed by them. Excuse me. So a few main types of medication to be aware of in terms of Parkinson's. We've got our dopamine agonists, so these basically mimic the action of dopamine in the brain, which we know is ultimately the key issue, and the depletion of dopamine is a problem and why Parkinson's occurs. So that's going to be number one. Levodopa is your single most effective drug that actually treats the symptoms of Parkinson's. And that's really commonplace in pretty much everybody's treatment plan, but it does come with some side effects, okay, as most meds do. So with nausea, sedation, as we noted, postural, hypotension, and potentially also some psychiatric symptoms like hallucination. So it's really important to understand if your patient or your individual you're working with is taking these kind of meds, and being aware of the possible side effects again. And then we've also got carbidopa, which facilitates the optimal action of the drug that we previously spoke about, levodopa. So what it actually does is it prevents the breakdown of levodopa before reaching the brain, and therefore it tries to allow a lower dose to be taken, which obviously is going to reduce the side effects. So those two kind of work together. Now, just to quickly note, there is possible surgical intervention with Parkinson's. This is very much more in your severe cases, but the main surgical treatment is what we call deep brain stimulation, and that's where we're electrically stimulating the deep brain stimuli, okay, as the name implies. So it's usually a surgical intervention of choice when the motor complications aren't being managed sufficiently via the use of medications, okay? So it's kind of the next step, the next treatment. It is known to be more effective than medical therapy in advanced PD, and like we said, particularly in trying to improve that motor function and the consequent quality of life. So just something to be aware of. You don't need to know the ins and outs of it, but it's just good for your awareness. Other treatments, okay, so there's more than often going to be speech therapy involved. As we know, there's going to be those issues with the speech. Occupational therapy, which is very much focused on performing the activities of daily living. So, just doing your basic tasks around the house, bathing, transferring, all these different types of things. Psychological therapy and counselling is going to be really important. And then the last one is exercise, okay? And there's a heap of evidence to show that exercise should certainly be prioritised in the overall treatment plan of a Parkinson's patient. So just to quickly note, what are some of the benefits of exercise, okay? So there's a few we'll discuss now. So regular exercise is going to reduce or delay secondary symptoms, and that's certainly a big goal of the exercise program, okay? So trying to think about musculoskeletal, cardiorespiratory symptoms that occur as a result of physical inactivity. We obviously want to try and prevent them as much as possible. So we're trying to prevent any further decline, trying to delay over any other potential pathologies, comorbidities occurring, etc. Okay. Gait performance is huge, so we know if we can exercise people and we can apply some kind of specific gait interventions, but ultimately their gait is going to be maintained and again prevent any further decline. We can also provide benefit for the non-motor symptoms, so things like trying to improve sleep. Okay, so again, there's a heap of research showing that exercise is really beneficial for good, healthy sleep, and also obviously the emotional well-being side of it, which we speak to all the time. And that's going to all lead into improving that overall physical and mental quality of life. There is also, just to note, there is also a possible neuroprotective factor. However, just note the research to date has mainly been in animal models, so it's kind of suggested, but it's kind of very minimal in terms of human research at this point. So if we want to try and do some exercise testing with our Parkinson's patients, we're definitely going to want to make sure we assess their aerobic capacity. Once more, preferably we're going to have them in a seated position, so using again a recumbent bike, for instance, some kind of seated ergometer where there's really, really low risk of falling. Gait is going to be an important one, so we can just simply do a subjective observation of the gait over, say, a 10-metre track. And then our balance tests, looking at both static and dynamic balance, are going to be really crucial. Okay, so various protocols. You've got your tandem stance, which you can see this lady doing on the right, and your single leg stance. Timed up and going chair sit to stand, they're a little bit more your functional capacity, but there is a built-in balance component there, as well as a little bit of strength, but they could be various protocols to use as well. Range of motion, flexibility, so really trying to look at the major joints. Single leg raise could be an example there. And when it comes to strength, dependent on the individual, we might be relying on machines, we might be looking at dynamometers, looking at hand grip strength as a starting point, for example. So the major goals, we want to delay disability as much as possible. So that's going to be key. As we know, guys, we want to prevent our secondary complications and we want to improve quality of life. Okay, so, you know, pretty global, pretty much relatable to all our different chronic conditions. But again, we can say it as many times as we want, but when it comes to working with an individual, if we can hit these things and make it happen, it's going to have a profound impact on their life ultimately. Key focus areas, so for Parkinson's, as we kind of just noted there, improving the walking gait, at least maintaining it and preventing any deterioration, trying to build up the capacity to independently transfer themselves, whether that's from a chair to standing, or, you know, thinking about getting in and out of the shower, etc., out of bed on the morning. Balance, joint mobility, and also muscular power, because we know it's muscular power specifically that has a really big transfer to functional capacity. So we're always talking about strength, and strength is obviously absolutely important, and that's kind of one of your big blocks at the bottom, okay? But once you've kind of got a strength stimulus in place, you also want to look at the power improvement. And what we mean by that is the ability to express strength quickly, okay? So if people need to stop themselves from falling or kind of balance themselves, or you know, even just walking up the stairs, it actually requires a quick expression of strength. So this is why muscular power is really important when it comes to some of your ADLs and functional capacity improvements. So we've got ACSM guidelines again, and I do apologise, I presented them as best as I can, but they're a little bit crunched together there. But just the point to make, guys, that specific guidelines are actually based on limited literature, so there's not been a whole heap of investigation into kind of the optimal exercise dosage for your Parkinson's patients. So the kind of fit principles, your frequency, intensity, time and type, are pretty much in line with just your generally healthy adults, okay? But obviously, the point is you're going to have to look at the individual in front of you, you're going to look at their specific limitations, and obviously address and tailor the exercise accordingly, okay? So you can have a look through, there's a few different kind of points at the bottom there when it comes to type, look at resistance, so again, all your various modalities, talking about the different ergometers when it comes to the aerobic part, trying to perform active stretching for flexibility where possible, but if it's not possible, then even low intensity passive stretching can be useful in those early stages. So exercise considerations, so just thinking about our physical considerations to start, we've got bradykinesia, so thinking about movement initiation, okay, so we're potentially going to have to get hands-on, support these individuals, really help get the movement started. Postural instability and impaired balance, as we said, is going to be absolutely huge. So it's really important to make sure you safeguard the environment. You know, is it reasonable? Is it feasible what you're asking these individuals to do? Is it posing too much of a risk? You might have to strip it right back and, you know, really start with some low intensity, simplistic tasks to start. And then as you gain confidence in their ability, and obviously they're improving those capacities, you can start to add more complex, you know, balance and things like this. Patients are certainly going to have a poor walking economy, so you have to really pay attention to that fatigue as well. You don't want to get them trying to do heaps in the first 5 minutes of your session and then kind of wear them out and not have a lot to work with for the rest of the session. A few autonomic nervous system considerations as well, so potential cardiovascular dysfunction could be present, thinking about your arrhythmias. Obviously, if they've undertaken, you know, you should have a sort of a record of all of this lot so you're aware, but just be wary. You potentially got different comorbidities and pathologies to consider as always. Postural hypertension, so if you're asking people to stand up, just be wary, depending again what meds they're on, that could have an influence. Thermoregular disturbances, so thinking about the actual temperature of the environment, and also knowing that the medications that they're on, because what we do know is levodopa can actually cause bradycardia and dyskinesia, okay, so it can actually cause like this abnormal voluntary movement, so you might get limbs kind of, you know, flinging out and all this kind of stuff, but you just need to be aware of what to expect. A few other considerations, so going back to balance once more, we talked about sort of safeguarding, but specifically you might need to use, you know, have parallel bars available for that kind of gait training. consider the burden of any kind of cognitive decline and possible dementia. That's really important for how you tackle, your exercise, and more so in the delivery and the cueing and the interpersonal side of things. But once more, it's good to have, a family member on board that can really assist with that part as well. Emphasize your fall prevention, education, and education. I don't know why I've said that twice, sorry. But yeah, just again, keep, taking note of why you're doing what you're doing, trying to help them transition and take this stuff, take the work that you're doing in the gym or the exercising environment back into the home as well. Okay, I don't think there's anything we haven't covered there. And yeah, just be flexible with your cueing, guys. You shouldn't only have the ability of teaching an exercise in one way with one description. You need to be adaptable, and you'll quickly learn, as you're getting to know a patient, you'll quickly know what potentially works and doesn't work. But even when you're working with, your healthy populations, you often need to have a few different ways of teaching and cueing movements. So just keep that in mind. And that's pretty much it for the end of the lecture, guys. I've just got one video I want to show you here, which is actually on the exercise rehabilitation process of a patient. I apologise, it's set in the States again, so there's a bit of a cheesy introduction to the video. I'll just pull it up here. So 4 minutes. Now, it doesn't go into like real complex details, but I think it's just a nice way to kind of summarise exercise in Parkinson's disease, and it kind of talks you through this one gentleman's journey, so we'll give it a crack.
I love exercise because it has so many benefits, but for some, exercise can be especially important to keeping them on the road to health. Just ask Ed McCaskey Jr.
I've always been pretty active. Started with 5Ks and worked my way up to eventually to the marathon level. Afterward, that's where the satisfaction comes in after a good workout.
But about 10 years ago, Ed got some serious news about his health from his doctor after complaining of limited flexibility in his right hand.
He said, "I think you may have Parkinson's disease." Had a follow-up session with a movement disorder specialist who confirmed Parkinson's. Found out its cause is unknown, it's progressive, and there is no cure. And that combination of news was rather startling to me.
Parkinson's disease is when certain cells in the brain start to degenerate and die. They're the dopamine-producing cells of the brain. Dopamine is involved in movement. One of the most commonly sought after consultations in the office would be for a tremor. Then declining balance, multiple falls, stiffness of the muscles, lack of expression, a feeling of sadness or apathy or depression.
While there's no cure for Parkinson's disease, there have been many advancements to improve quality of life for the patients.
It's a multidisciplinary approach, medications to enhance the dopamine that is lacking. Exercise is also as important as your prescription, and you can see the improvement. It's remarkable. Right alongside of your medications, you should think about a good exercise program, be guided and trained by good therapists, because you have years ahead of you.
Research has recently shown that individuals with Parkinson's who exercise on a regular basis can possibly slow the progression of their disease.
Ed took that to heart and joined the class program at Northwestern Medicine Lake Forest Health and Fitness Center.
The exercise classes are free for those with Parkinson's. We really want to focus on flexibility, aerobics, and strength and resistance so that they will experience improved gait or walking, improvement in balance, and just improvement in their overall daily activities.
Monday, Wednesday, Friday, there's a pedaling for Parkinson's class. I do weight training, running. There is no cure, but you do have a say in how you're going to deal with it.
Exercises for over 2.5 hours per week. It improves the joint stiffness, it improves the posture, it improves the muscle weakness.
Those are benefits Ed noticed as he made targeted exercise a regular part of his week.
Parkinson's symptoms, they seem to be greatly reduced after a good workout. More alertness, more flexibility, my gait is improved. The benefits kind of carry on for the balance of the day.
In addition to the physical benefits, Ed says the program has provided him a sense of community with others who are also living with Parkinson's.
There's a camaraderie among the group. It's almost an informal support group type of environment.
Ed is a very dedicated individual to exercise classes. He is in the classes, he works out regularly, and he in turn also encourages other participants who are in the classes with him.
Ed hopes to inspire others living with Parkinson's to start exercising and take charge of their health.
The benefits are real. I haven't seen any significant decline. Find a class that's suitable to your level of ability and get over here and get moving, and the payoff will be there, guaranteed.
It's never too late to start exercising. Exercise right now is the best thing that they can do to help manage their symptoms.
That's the goal, is to keep ahead of the Parkinson's disease, and by doing a good exercise routine, you have nothing to lose, and everything is on the positive side. Do something about your circumstances.
I just love that. Thank you so much for sharing your story, Ed.
Get rid of that. So yeah, I just thought that was a nice kind of summary, and it's always good to see it from you know, the patient side of you. Obviously, like, I thought a few things I took away was when he spoke about finding out he had Parkinson's, knowing there's no cure, and you don't really know why it's occurred. Like, you can imagine kind of the emotional roller coaster that must come with that. But then thinking about controlling the controllables, and okay, if exercise is going to be really beneficial for trying to help control my symptoms and potentially delay the progression, then that's one thing I'm going to sort of tackle and charge at, which I thought was really cool. And also just noting that he actually said when he did exercise, his symptoms for the remainder of the day were often reduced, which I think is a really cool thing to take away as well. So obviously very convincing, a nice summary of what we spoke to. There's heaps more out there, guys, so don't just think that's, you know, you can go out there and do plenty more research. I was aware of a few specific Parkinson's sort of exercise groups and things in Perth a couple of years back, so I'm not familiar with sort of too much right now, but there's certainly usually, similar to what you just saw in the video, you know, there's certainly usually different things out there and available, and no doubt there's a couple in Perth if you want to try and explore those. Thanks for your time today. We will be in touch regarding